This is the third and final series on analgesics and antipyretics in the Self-Care and Complementary Medicines course. You should be familiar with this diagram. At this time, we're going to talk about salicylates, and our common salicylate used over the counter is aspirin, which has activity on both COX-1 and COX-2. Due to this central and peripheral inhibition, this leads to the inhibition of prostaglandin synthesis. By decreasing prostaglandins, it reduces the sensitivity to initiation of pain impulses at the site of inflammation and trauma. Its onset of action is about 1 to 2 hours, and so you can tell that this is significantly longer than the other products that we've already discussed. Its duration lasts about 4 to 6 hours. It's absorbed slowly from the GI tract. It's metabolized by the plasma and converted to salicylic acid and eliminated via the kidney. Aspirin is not recommended for use in pediatrics. While you will see it used for specific conditions, including some cardiac conditions in pediatric patients, this should not be a product that you would recommend to a pediatric patient over the counter. In particular, it's recommended to avoid the use in anyone under the age of 19 years of age. You'll see in different areas, including the text, that will talk about different age ranges. But as a general recommendation, stick to only recommending aspirin in your adult patients. Use in adults is 650 to 1,000 milligrams every 4 to 6 hours. However, you'll see lower doses used for cardiovascular effects, like 81 milligrams to 325 milligrams per day. The max analgesic dose for self-care is 4,000 milligrams. And the other thing that's important to note is that about 4,000 to 6,000 milligrams is actually needed for anti-inflammatory effects, which brings together the max analgesic dose combined with kind of its efficacy range, can lead to some concerns with toxicity because it's so close. One additional point. The reason that we avoid the use of aspirin in pediatrics is due to the risk of Reye's syndrome. Some common safety concerns with the salicylates, similar to our discussion of NSAIDs, is GI irritation and bleeding, which can be caused by both local and systemic effects. However, this is both dose, duration, and age dependent. Enteric coating can be beneficial for patients who are at risk. Inhibition of platelet aggregation means that this is actually contraindicated with patients who have bleeding disorders and should be held for 7 days prior to major surgery or for several days after. Some patients may have an aspirin allergy, and their symptoms would be urticaria, angioedema, or bronchospasm, and it typically occurs within 3 hours of ingestion. There's a number of risk factors that would increase a patient's likelihood to having a salicylate. And this would be if a patient has asthma, they're 20% more likely to have a sensitivity to both aspirin and NSAIDs. As mentioned before, there is a cross-reaction with NSAIDs, about 98% with ibuprofen and about close to 100% with naproxen. This chart lists some of the common drug interactions seen with salicylates, including those with NSAIDs, anticoagulants, valproic acid, antihypertensives, methotrexate, and alcohol. These are not required for you to memorize for class. However, they're just important points for you to probably use in the future. There are some safety considerations, in particular with salicylates, that they should be avoided in pregnancy and breastfeeding. You should avoid the use in patients with a history of gout and hyperuricemia because it can increase your uric acid levels. And salicylate toxicity, which is something definitely to keep in mind and be concerned about in patients who are especially using very high doses of aspirin. Salicylate toxicity is consistent with tinnitus or ringing in the ears, and also confusion, nausea, vomiting, and diarrhea. I mentioned earlier about Reye's syndrome and the use of aspirin in children. Reye's syndrome is consistent with an acute illness in children, typically under the age of 16 years, but the cause is unknown, and it typically has occurred within 1 week after receiving aspirin for treatment of a viral infection. Signs and symptoms include nausea, vomiting, lethargy, hypoglycemia, hepatic injury, and CNS damage. We want to avoid Reye's syndrome in our patients, and therefore that's why we need to be incredibly cautious about using aspirin in this particular, in our pediatric patients. Hopefully you've identified that there are some other products that you may use that would be better used to be able to help patients, even adult and pediatric patients. I wanted to touch just briefly on some of the combination products that are available. There are a number of them on the market. They may be more potent because of the combination of products. However, this does increase the potential for overuse or abuse or overdosage because of the amount of ingredients that are in them. Caffeine is one in particular that you can see is shown in a lot of different products that are listed here, particularly all of these being used for headache. You have antihistamines that are used in combination, as well as decongestants, which we'll talk further about when we get to the cough and cold section. So, some important things to remember about the products. For anti-inflammatory effects, NSAIDs are the preferred therapy. For analgesic effects, they're similar among agents, but it's important for you to remember what particular patients we need to be cautious about using each individual agent. Response to NSAIDs are patient-specific. However, similar efficacy is seen between the NSAIDs that are available. And lastly, we need to consider a patient's preference. In particular, there are a number of products that are available in a number of different dosage forms, and we need to make sure that we can find a dosage form that works for a patient, all the while maintaining safety and efficacy. Special considerations for some of our special populations. So in children, we really should be avoiding the use of aspirin. Acetaminophen is safe for use, as well as NSAIDs are. But remember, ibuprofen should not be used in children under the age of 6 months, and naproxen is only indicated for 12 years and older. During pregnancy and lactation, aspirin should be avoided. Acetaminophen is actually fine for use, and NSAIDs are fine for use, however, they should be avoided in the 3rd trimester. And for geriatric patients, we need to be cautious about the use of aspirin due to the increased risk of GI bleeding, particularly for patients that are over the age of 60 and have concomitant diseases. Acetaminophen is typically our safe for use product, but make sure that we're also not going over that maximum daily dosage of 3,000 milligrams per day or 2,000 milligrams per day for a patient who drinks alcohol or is taking warfarin therapy. And then finally, NSAIDs. Again, we need to be concerned about the potential for an increased GI risk or GI bleeding risk, and consider how the patient's cardiovascular health is and whether or not that they would be a candidate for NSAIDs.